We'll start off the review today by going through the PFT exam. We'll go through the ANAVA worksheet and the answers to the questions on the worksheet. And then we'll review the patient assessment form to make sure that you have everything before you turn it in. So for the exam, everybody did quite well. The first question that asked whether it's restrictive or obstructive, the patient did have a low FEV1 over FVC or FEV1%. So it is an obstructive disease. I ended up giving everybody credit for it because I went in and changed it for future tests. But for this test, it wouldn't let me grade it. So at the end, I just added 2 points to everybody's score. So that was an obstructive disease. And then it asks, were any changes noted after the bronchodilator? And you look at the FEV1, it went from 0.9 to 1.5, so more than 200 ml improvement. And that gave more than a 12% change. FVC went up by more than 200 mLs. So yeah, good response to bronchodilator. DLCO is the diffusion limited gas, carbon monoxide. We're looking for the diffusion capacity of oxygen across the alveolar capillary membrane. And it asks, what is it used to measure? And it's measuring the transfer of a diffusion limited gas across the alveolar capillary membrane. Lung abnormalities that have decreased diffusion capacity. Chronic bronchitis has low diffusion capacity, not because there's any problems with the alveolar capillary membrane, but it's just difficult for inhaled air to get down to the alveoli. So because of that, it shows up as a diffusion limitation. Emphysema, yes, because you have loss of alveoli. So not as many alveoli are partaking in oxygen crossing over to the blood. So it's going to show up as diffusion limitation. Congestive heart failure, fluid ends up accumulating in the interstitial space between the alveolus and the capillary, and that prevents oxygen from going through, so yes. ARDS, there's a lot of pulmonary edema, washout of surfactant, collapsed alveoli. So yes, that's going to affect oxygen getting into the blood. Normal peak flow rate is 8 liters per second for adults, 450 liters per minute with different units. How do you calculate residual volume? Well, we can calculate FRC and then measure the person's ERV and subtract that to get residual volume. That's done with helium dilution and it's done with nitrogen washout. Why would it take longer for the gas to equilibrate when performing helium dilution? If there's a tumor in the airway, it's going to take longer for the air to get past that tumor and then back out again. So it just takes longer for the equilibration to occur. If there's loss of elasticity, we're going to have non-supported conducting airways and airway obstruction. With airway obstruction, it takes longer for the gas to equilibrate. It takes longer for the helium to get down to the alveoli. And if an airtight seal has not been established, we don't get equilibration because the helium keeps getting lost to the atmosphere. So what can you conclude if a patient has a decreased diffusion capacity? And would it be a neuromuscular disease? And the answer is no. So when you have weak muscles, that has nothing to do with oxygen getting from the alveolus into the capillary. So neuromuscular disease has nothing to do with it. Fibrotic disease, the fibrosis does occur in the interstitial space, and that causes more of a separation between the alveolus and the capillary. So yes to fibrotic disease. And then you looked at a pulmonary function report. It had a low FEV 1%. Bronchodilator was given, and there was no improvement afterward. Patient is on Advair at home. Their peak flow decreased to 60% of their personal best. What would you recommend? I gave credit to adding a short-acting beta-2 agonist. I also gave credit to contacting the clinician. Does a low hemoglobin affect accuracy of a diffusion limited study? And the answer is yes, it does. And if there's a low hemoglobin, it's not going to absorb the carbon monoxide, and the carbon monoxide gets exhaled, and the computer interprets that as a really low diffusion capacity. So hemoglobin does affect the results. A 13-year-old has a good FEV1 at rest, but 5 minutes after exercising, the FEV1 drops to 61%. What can you conclude? That they have exercise-induced asthma. Patient who is asymptomatic at rest, they've got a normal pulmonary function test, but want to rule out asthma, then you would give them a methacholine challenge. Not sure why a lot of students miss this question. But I know everybody, a lot of people left lecture that day. I don't know if that's why, but yeah, if you have a normal PFT at rest and the patient is complaining of symptoms, then maybe they do have reactive airways. And the only way to find out is to give something that might induce bronchospasm. And if it does induce bronchospasm, then they do have reactive airways and they are diagnosed with having asthma. And you guys did really well on the loops. There was one that was fixed intrathoracic airway obstruction, such as tracheal stenosis. And when it says fixed, we're looking for the same flows, or limited flows on inhalation and limited flows on exhalation. So anytime it says fixed, we know it's affecting inspiration and exhalation. And I think that was it. You guys did really well. And then figuring out peak flow rates at different lung volumes. So after 25% of lung volume is exhaled, 50%, 75%, you just find the vital capacity, the volume of the forced vital capacity, and multiply by 25% and find out what volume that is. And then you have to look at your flow volume loop and see what the flow rate is at that point in time. And it was just really good. Okay. So any questions? All right. Now for the NAVA worksheet. Let me pull that up. My brain is tired today. Oh my goodness. We talked about that in advanced equipment. So let me go to advanced equipment. I'm pretty sure I have it uploaded in here. Last lecture, Nava, and handout. Loading. Please stand by. Let me make it bigger. Okay, let me share the page. So just to review Nava, once that EDI catheter is in place and it can sense when the diaphragm is contracting, that information is then sent to a module on the side of the servo ventilator, and the servo knows when the diaphragm starts to contract. And of course, when the diaphragm starts to contract, that's when inhalation is beginning. So it can synchronize the very beginning of the breath by delivering some pressure support. The signal that is being measured from the diaphragm is measured in microvolts. So we know that with normal work of breathing, the amount of muscle contraction is registered as between 5 and 15 microvolts. So normal contraction of the diaphragm, that's how much energy is being detected. If the number is higher than 15 microvolts, that tells us the person is working really hard to breathe. If they are working hard to breathe, we can help them. And the way that we help them is we turn on a Nava level. The higher the Nava level, the more help they get from the ventilator for those pressure support breaths. If we're using a Nava level of 0.5 to 1 centimeter of, no, I'm saying it backward, microvolts per centimeter of water, that's not much help. And most likely, once the patient's extubated, they're going to do fine because they're not requiring much help from the ventilator. If the Nava level is between 4 and 7, then it's possible to wean the patient, let them start doing more work on their own. So we would start decreasing the Nava level even more than what it's on. But if they're requiring a Nava level higher than 7, that tells us we have to give them a lot of help in order for them to move air in and out of their lungs. Okay, and then to determine the amount of pressure support that will be delivered, you get the Nava level, multiply by the EDI signal. You take the peak minus the minimum, and that equals pressure support. During lecture, I gave you the formula that was in the worksheet, but I didn't say that right. It's in the website, the Servo website talks about NAVA. They add PEEP to it and come up with pressure support, but that doesn't make sense. Once you add PEEP to your pressure support, now you're looking at your peak inspiratory pressure. I know you guys understand that, so that's why I just wanted to point that out. So here it's just asking for showing the pressure support, and then after that we could add PEEP and see what the peak pressure would be. Question number 1. The best part about NAVA is that there is no asynchrony present with the ventilator breaths. The pressure support breaths begin without a delay. Pressure support breaths end when the diaphragm relaxes. So that's really cool, but on the other hand, what is a disadvantage of NAVA? Can I write on this? So a disadvantage of NAVA is having to put an invasive catheter into the patient's body in order to detect their inspiratory efforts. So the disadvantage is having to use an invasive catheter. So having to use an invasive catheter to detect inspiratory effort. All right, question number 2. Compare the following settings to the values listed above. Determine if the amount of NAVA level support is adequate. So it shows the EDI peak of 18 microvolts. If we subtract the EDI minimum, remember that's just the noise or the electrical activity in the diaphragm when it's at rest. So we can subtract that. So 18 minus 5 is 17.5. So 17.5 is above the normal. We said the normal is between 5 and 15. So is the NAVA level support adequate? So patient is getting 1.3 centimeters of water per microvolt. Is that enough? Do you think they need more than 1.3? Where should I put the answer? All right, so how did I come to that conclusion? I saw that the EDI peak is more than 5 to 15 microvolts. So I know the patient's working hard to breathe. So how can I help them? I can increase the NAVA level. So increase from 1.3, usually 0.5 at a time. So 1.3 up to 1.8. and then see if their EDI signal drops between 5 and 15. Number 3, compare the following settings to the values listed at the top of the page. Determine if the amount of NAVA level support is adequate. We're going to do the same thing. We're going to look at the EDI signal, see if it's between 5 and 15. If it is, then we're giving enough support. So we look, we see the EDI peak is 18 minus 0.5. It's at 17.5 microvolts. That's above the 5 to 15. So we know the patient's working hard to breathe. This person's on a NAVA level of 6 centimeters water per microvolt. Is that enough? And the answer is no. So here we've got EDI peak of 17.5 times 6. And what does that come out to be? It says 105. Is that correct? 17.5 times 6, 105. Yes. So we need a pressure support of 105 on this patient. Not that we dial in the pressure support. This is what the ventilator gives when it's giving a NAVA level of 6 centimeters of water per microvolt. It's going to generate a pressure support of 105 centimeters of water. That's a lot. And going through neonatal ICU, I'm seeing these high numbers, and it boggled my mind. Like, how can we be ventilating with such high pressures? And I was given these really long answers by the company rep, and it didn't make sense to me until I realized it's all airway resistance. So these babies have nasal CPAP in, and for the pressure to get through the nose, through the upper airway, and into the lungs, it was taking that much pressure to deliver some air to the lungs. So it's a lot of airway resistance, and that's why it took so much pressure to ventilate these babies.
So there's not actually any barotrauma occurring. It's just the high airway resistance.
Yes, perfect. That's correct. Okay, I think this continues. Here we have an EDI peak of 4 microvolts minus the minimum of 0.5, so 3.5 microvolts. What is your recommendation? The patient's on a NAVA level of 4 centimeters water per microvolt. So if we say the normal is between 5 and 15, and this patient has an EDI peak of 4, they're not working very hard. So that tells us we're helping them too much with the ventilator. We want to take back some of the work of the ventilator and let them work a little bit more to keep that in range of 5 to 15 microvolts. So NAVA level of 4 should be reduced. So I wrote, we are giving too much help from the ventilator. We need to reduce the NAVA level. And again, we go down by 0.5 at a time, or up 0.5. Reduce the NAVA level. And when we do, we will notice the EDI peak will increase. So give them less help, and now they have to do the work, and we'll see that we'll have a higher microvolt, higher electrical activity in the diaphragm. Okay, question 4. We have, is the NAVA level support adequate? EDI peak is 10 microvolts, EDI minimum 0.5 microvolts, so we have 9.5 microvolts. The NAVA level is 3 centimeters of water per microvolt. And we see that we're delivering 30 centimeters of water for the pressure support. So is the NAVA level support adequate? And again, we look at the EDI peak. We want it between 5 and 15. If it is, then yes, the NAVA level support is adequate. So we have 10 microvolts. We come to the conclusion that yes, the support is adequate. Question number 5, calculate the amount of pressure support if the NAVA level is 7 centimeters of water and the EDI signal is 10 microvolts. Okay, so to figure out the amount of pressure support, it's the NAVA level times EDI signal. On here, it doesn't give us the minimum. Let's make up a minimum. Let's say the EDI min is 0.5 microvolts. So to get the amount of pressure support, it's 10 minus 5, so 9.5. Times the NAVA level of 7. So 9 times 7 is 63. 66.5. So I took the EDI signal, I took the EDI peak minus EDI minimum, and I got 9.5 microvolts. Then I multiplied by the NAVA level, and I come up with a pressure support of 66.5 centimeters of water. I guess that needs to be rounded off, doesn't it? So pressure support of 67 centimeters of water. Number 6, calculate the amount of pressure support if the NAVA level is 2 centimeters water per microvolt, and the EDI signal is 5 microvolts. It doesn't have an EDI minimum, so we'll add that. So it's going to be 5 minus 0.5. So the EDI signal times NAVA support of 2. What did I do? So 4.5 times 2 would come out with 9. So the amount of pressure support will be 9 centimeters of water. Okay, number 5, is EDI a setting on the ventilator, and where does this number come from? So the EDI is not a setting. It is the electrical activity of the diaphragm. What would cause an EDI of 0? Why would there be no signal coming from the diaphragm? So we talked about this in lecture. If we are overventilating the patient, they're not going to need to breathe anymore, so the signal would be 0. I'm sure there's better wording, but I came up with, if the patient is receiving adequate ventilation from the ventilator, they will have no need to breathe above what the vent is giving them. So the signal would be 0. If the catheter comes out, or it's misplaced, the signal will be 0. And let's see, what else did we talk about? Oh, severed phrenic nerve. Did we mention that one? So if the phrenic nerve is not communicating with the diaphragm, if the fracture of 3, 4, and 5, then the phrenic nerve is not working, and then there won't be a signal. So phrenic nerve paralysis. How about phrenic nerve damage? All right, so that was the last question. Yes. And now to pull up the patient assessment form, or let me just pause the recording for a second and then I'll restart it. Oh, and I just want to make sure I'm sharing the right screen. Oh, no, I can't. So I'm assuming that everybody can see your screen.
I hope so.
Okay, so we're going through the patient assessment and what to put down for certain categories.
Yes. So this part, I'm just gonna, so this is what I was wondering, because I feel like in the example, she kind of almost just pasted the same thing over and over again, for the primary diagnosis, patient's current clinical situation. It kind of all seemed like the same thing posted over and over again, to me, at least. So I'm wondering, I don't know, maybe I should just,
So patient had a intracranial hemorrhage. That was the diagnosis.
yes,
And then the current clinical situation, sometimes nothing different occurs, like they're intubated on the ventilator. You could mention if there's been any findings after that initial diagnosis. Like sometimes
Oh.
they're brain dead and they need an apnea test, or there's no cough reflex, or they develop pneumonia. So all of those would be part of their current situation that were not part of the diagnosis.
I see. Things like posturing and I guess. Okay.
Yeah, the posturing shows that there is brain damage to the brainstem. If I'm
Oh,
remembering
really?
correctly.
Yeah, I was learning about posturing at clinicals, and I was like, I have no idea what that is. And it was
Okay. Yeah, I think that's one of our last lectures for neonatal and pediatrics, so we haven't talked about it yet. But a certain type of posturing indicates where, how low in the brainstem the damage has occurred.
Mm,
And from that, do they want to withdraw life support?
yeah. Okay.
So all of that would be the current situation.
And then as for the past medical history, I'm wondering if chronic heart failure and what else did she have? She had chronic heart failure and hyperlipidemia. I'm wondering if those are applicable to her current, if it's relevant, or if I should not include it.
Yes. So
Because I know heart failure.
we have hypertension, and that led to the heart failure.
Mm.
Hypertension can also lead to blood vessels busting in the head.
Oh. Is that what hyperlipidemia is? It's high blood pressure?
No. Hypertension is high blood pressure.
Okay. I was
high lipids, high fats in the blood. Could be uncontrolled diabetes,
Mm.
things like that.
Okay.
So I don't know how the lipids would play a role in this bleed.
Okay, that's good to know. So that's not important. It's the heart failure that's important.
Yes.
Okay. And of the patient's current and past history, which problems contribute to respiratory complications? I think heart failure definitely contributes, right? Because if the blood isn't circulating correctly, the gas exchange doesn't occur correctly, and it kind of messes everything up.
Yes, well stated.
Okay.
So there's a lot of infiltrates in the lungs when there's congestive heart failure.
Mm.
And that makes it difficult to breathe. It affects oxygen getting into the capillaries.
Okay. And this stuff I understood okay, here we are. So this is the tricky part for me is so the total respiratory rate. My patient was breathing 20 breaths a minute. They're breathing normal rate set on the ventilator. And I know respiratory rate affects tidal volume and minute volume. Is that good enough explanation for the significance, or should I write anything else? Or
Respiratory rate doesn't affect tidal volume.
oh, I meant just minute volume. I don't know where my brain was.
So everything looks so nice and neat, Summer. Did you
Thank you.
have to resize every box after you typed it in?
Yeah, because it wouldn't all fit.
Okay. I don't know if I can do something on my end, but
That's
you for
okay.
letting me know. So the patient is not assisting, right?
Yeah, the patient
They're
is
set at 20 and their total respiratory rate is 20.
Yeah.
So I would want to know the connection. Like, did the bleed into the brain affect the drive to breathe? Did it affect the brainstem? So if you were to take this person off of the ventilator, would they have no respirations? Because
That is
their
a good question.
brainstem is damaged?
As far as I know, the brainstem, I don't think it was damaged. It was just the intervertebral small subarachnoid bleed, intracerebral and intercerebral hemorrhage. And of course, she's going to go for an angiogram. But I didn't read anything in her chart about the brainstem being affected. And they haven't tried to let her off the ventilator or anything. So the patient, I know they're breathing. They're not breathing over the ventilator. I wish I could answer that better.
Yeah, I guess I'm looking for you to connect the two. Patients not breathing over the set rate of 20. It could be because they have a good blood gas, or it could be because their brainstem was affected by the bleed.
Okay. I think at this point they did have a good blood gas. Where was their blood gas? So that could be it. Yeah, they did have a good blood gas. So
Yeah.
that's probably why. Patient is not breathing over the ventilator because they have a good blood gas and there's no need to breathe over.
Okay, yes.
Okay, I see what you mean. Let me see if I have to resize this. Will it fit?
Very good.
Okay. Okay, good. Okay, now spontaneous tidal volume. For mine, the patient's not breathing spontaneously, but a spontaneous tidal volume is important, ensuring a patient is able to maintain enough ventilation and oxygenation when breathing spontaneously off the vent. Does that make sense, or maybe not good?
Yeah, I mean, it's true. But is that what I wanted you to realize? Patients in PRVC, right?
Yeah.
So they're not going to have any spontaneous breaths in PRVC.
Mm-hmm.
So that's why you just gave a general statement about spontaneous breathing.
Exactly.
Okay, that's good. That's good.
Okay, good. And then their minute volume was 7.9 liters a minute. And I wrote the patient has a normal minute ventilation between 6 to 8 liters a minute. And I just didn't know what else to write. I guess that the normal minute ventilation is important because if they have a super high minute ventilation, then their respiratory muscles would tire after a while and they might become apneic.
Yeah, very good.
Should I write something like that? Or
yes.
Okay. Okay, I understand then. Now peak inspiratory pressure. Hers was 15 centimeters water. That's a good peak inspiratory pressure. Now how do I apply this? Why is this important? This is important because how do I explain this? I don't know how to.
How do we state the obvious, right? It's a good pressure. We would be concerned with high peak pressures.
Yeah, because does that indicate perhaps they require more support?
Yes, very good.
Okay, so this is a good pressure, so we would be concerned if hers was much higher because it would indicate that she would require more support and perhaps wouldn't be a good candidate off the ventilator because she wouldn't be able to maintain. Or is that not?
Perfectly stated.
Okay, good. Whew. And would I add anything else there?
No, that's exactly the takeaway message that I would want you to have for peak pressure.
Okay. I think I know this stuff and I just don't trust myself.
Yeah, you know it very well. I'm impressed.
And the plateau pressure, hers was 13, which is a good plateau pressure. And that is good because that shows that there's no, I guess, the difference between, is it the peak and the plateau pressure? The greater the distance difference, the more resistance or something.
Yes, that's true.
Um,
So that's one takeaway point. If plateau pressure is close to peak pressure, airway resistance is low.
so that is a good thing. She's got a good airway resistance.
Mhm.
What else?
And what does it tell us about the pressures in the alveoli?
It tells us that the pressures in the alveoli are come on, Summer, come on.
So that's not bad, right? To have a plateau pressure of 13 centimeters of water. We're concerned when the plateau pressure is 30 centimeters of water, because that amount of pressure in the alveoli will damage the alveoli.
Yeah.
So having 13 centimeters of water as the plateau pressure, we're not generating a lot of pressure in the alveoli, so the alveoli are safe with this pressure.
Okay. The alveoli are okay. They're not being damaged. They're safe.
Yeah,
Okay. So I would put something like that there.
yes.
Okay. And then the driving pressure. You like my little.
Yes, thank you for the reminder. I like that.
And I'm gonna be honest, Yvonne. I did my research on driving pressure, but I totally forgot why it is significant. I know in my research I found out it's almost better to use driving pressure rather than using PEEP or peak inspiratory pressure,
Yes.
because it's more, there's more better mortality outcomes when using the driving pressure, but I totally forgot what you told us. I'm sorry, Yvonne.
Yeah, keeping it between 12 and 15 centimeters of water
Mhm.
assures that you have safe ventilating pressures.
Okay, safe ventilating pressures. And hers was 8, so that's good. Her driving pressure was between 12 to 15. So hers is low. What does that
Low
mean
is
if hers
good.
is? Oh, low is good. Okay.
Yes.
And then, so what is the, I guess the significance is that
So the significance is if we go over 15 centimeters of water for the driving pressure, we're damaging the alveoli.
okay. Okay.
So if over 15 is dangerous and damages the alveoli, it's good that her driving pressure is only 8 centimeters of water.
Okay, so on the lower end is good. Got it.
Yes. Yes.
So far, she seems to be doing pretty all right with her parameters.
Yeah.
Her auto PEEP was 0. I just wrote a general statement like auto PEEP can cause increased workup breathing, barotrauma, and can suppress the patient's ability to trigger a breath. The patient doesn't have any auto PEEP.
Beautiful. Okay.
Okay, and the PF ratio, her PF ratio was 418. The PF ratio is used to identify ARDS, which is identified as being a ratio less than 300. The patient does not have ARDS.
Okay.
Is that okay? Or
Yes, excellent.
okay. And the PaO2 gradient, hers was hers was huge. It is 256.25. Okay. So 256.25. The AA gradient measures the difference between the alveolar O2 and the arterial O2. The A gradient is above the normal range of 5 to 10. When O2 is not able to transfer efficiently, the results is an elevated A gradient. This could be due to VQ mismatch, right to left shunt, or increased O2 extraction.
Increased O2 extraction.
I guess, what is it called? Is that not accurate? Like when the body needs to use more oxygen?
So when the body is using more oxygen, it will extract more. It will extract more from the blood, but over in the alveolar capillary membrane, it doesn't come into play in that area.
I see. So that was totally not supposed to be there.
That's okay.
Okay, but it's still, her issue could still be a VQ mismatch or a right to left shunt.
Yes.
Okay. Now, she was not a candidate for NIF. I think I wrote down these ones pretty good. NIF relies on patient's ability to follow commands and generate a negative inspiratory force. I guess I didn't write the significance though. Did I?
Well, you don't have her
Yeah.
values to say how significant they are.
That's true. So is that general statement okay?
Yes.
Okay. Patient's not a candidate for weeding, so okay. I included my little general statements. Now I was getting confused here when I got to the secretion colors because she is on antibiotics, but her secretions are thick, tan, and moderate. And when I was like trying to figure out what those were, like, isn't that painting the color of like perhaps an infection?
Yeah.
Yeah, that's what I was thinking. It was painting like she was having an infection down there. So that's the significance of the color and everything.
Yeah. Possible infection.
Okay. And then her skin, she was non-edematous, normal complexion, I guess no skin breakdown. Are those the kinds of things I would just put in there?
So for skin, where it says color, it means cyanosis versus pink mucosa. Skin turgor, that's when you squeeze the skin together, and if somebody's dehydrated, their skin sticks to itself. So that's how you determine turgor. And then edema is when you see swelling in the ankles, the hands, the arms.
Okay, good, because I had no idea what turgor was. So
okay.
Neurostatus. Oh, this is hard for my patient because my patient, they were taking her off the sedation. So her situation's kind of complex where she is moving. She's moving around. She's she's not following commands. So I don't know how to describe her neurostatus.
That would be good. So moves around but doesn't follow commands.
Okay.
I guess that would be what?
Okay. And then
unresponsive, but moves.
Unresponsive.
Yeah.
And why is neurostatus important? Because I mean, whether she can participate in like the weaning parameters and whether she can protect her own airway.
Perfect. Yes.
Okay. And for why is it important for a respiratory care practitioner to be concerned about fluid status? That's because if your patient is too edematous or is fluid overload or is retaining fluid, then the gas exchange is much more difficult. And that's kind of what I was thinking.
Yes, very good. So fluid overload causes fluid to accumulate in the interstitial spaces.
Mhm.
And then that'll affect work of breathing. That will also affect oxygenation.
Yes. And definitely if she's extremely could the fluid even get in her lungs and cause pneumonia?
So the fluid could be so bad that, yeah, it comes into the alveoli and they have like fulminating pulmonary edema.
Okay.
That's not where the pneumonia comes from. Pneumonia comes from inhaling some infected particles, whether it's virus, bacteria.
Okay, I see. Okay, Summer, get that out of your head.
Yes.
This one I understood. I understood that. Explain the importance to evaluate these values. I know why that's significant. I know why that's significant. Electrolytes, bun creatine. Okay. I think I understand everything else. I just have to finish writing it.
Okay.
But okay. Yeah, I just have to finish writing it. Okay, thank you, Yvonne.
You're so welcome. Those are good questions. I think everybody will enjoy hearing the review.
Okay, good. Mhm. Here, how do I give you control again? Let me see.
Can you stop share, maybe?
Maybe. How do I stop share? Aha.
You did it. All right, Summer.